Thanks, Rob, and thanks to the organisers for the invitation to speak. It's great to have a meeting like this in my hometown and just have to have a look at the day outside to know why it's great to be in Queensland. I've only got 15 minutes to cover off on what could be quite a big topic, so if I've skipped anything that you're interested in or maybe that you represent or manufacture, please forgive me and we can chat about that later. I mean, we've just heard some great studies coming through about the use of patches even in the elderly, so there is a lot happening in this space, and as I say, in the interest of time, I've plucked out a few important things. I've got a few disclosures, but similarly, the content of this talk is mine, although I have borrowed some slides from a number of different sources. And my talk will dovetail nicely with Paul Van Binder's talk from earlier, because obviously one of the strategies we have for improving how vaccines work in the elderly is to add an adjuvant. So there'll be a little bit of overlap, and so some of the slides that I've got I might skip over fairly quickly. So we know a lot of things stop working well when you get a bit older, and the immune system is one of those as well. And so we often refer to this as immune senescence, and this has a number of very significant implications. So there's a number of things that contribute as well. So there's the talk of inflammaging, so an inflammatory state, and that has a number of implications as well, both in terms of other conditions, but also potentially reaction or how certain infections will impact you. And then I've listed a whole host of things there, but in the interest of time, I won't go into the mechanism in any great detail. But the implications, of course, include the fact that it's much harder to get a response that you want to vaccines. You also get reduced protection to natural immunity, and this is part of why we see a number of these infections that we'll talk about have either a U-shaped curve, so cause greatest impact in the very young and the very old, or perhaps even just impact the elderly to a far greater degree. And it also increases the risk of the disease, and particularly severe disease. So that tells us that this population is clearly one that's the most vulnerable, particularly to bad outcomes, and the one for which we need to try and do a lot more. But this change in the immune system also leads to a whole host of other things. It's why we have a lot of age-related conditions, and also even things like our ability to protect ourselves against malignant conditions is also impacted. And we know that inflammaging and other factors were one of the things that saw really nasty responses in the elderly to COVID, in particular the so-called cytokine storm, and that really severe disease we saw in some. And so some of the strategies that the vaccines that I'll talk about utilise here, of course, include having a higher dose of antigen, adding adjuvants, and we've had a great talk on that already, but also changing how we use these vaccines, particularly giving it more frequently. And in addition to our impaired ability to protect ourselves and respond to vaccines, there's also a host of other risks that really interplay in terms of what happens. So we know that comorbidities is a big one, and I'll show a slide about risk factors for severe COVID. And of course, these are things that accumulate as we get older. 4 out of 5 Australians over 65 have at least one of these. We also then have treatment that we use for a lot of those conditions that are also age-related, whether it's malignancy or autoimmune or inflammatory conditions. And of course, that then changes both our risk profile and our ability to respond to vaccines. And of course, this is a population that's expanding. There's over 4 million people in our country at the moment, over 65 years of age. And we talk about our ageing population, so that number or that proportion is increasing. Then there's also some things in terms of the environment. So we know residential care facilities, for a host of reasons, is a very high-risk environment, not just because they have the most high-risk individuals. And we've heard a lot over the last few days, but it's a travesty that we have almost 500 current outbreaks of COVID-19 in that setting. Frailty is a very significant factor. We know that that contributes to risk of a lot of infections and also worse outcomes, and then is exacerbated by a lot of the infections we'll talk about. And then other factors like cognition and malnutrition. And again, I've just got some indicators down the bottom about just how different that risk profile is in this group. And it's a complex space for vaccines as well, and increasingly complicated. So we know the flus are recommended for everybody from 6 months of age, although we're not succeeding in getting that message out there. Funded on the NIP, both for young children as well as those over 65. But then we have improved options for vaccines that I'll touch on quickly that are available from 60. RSV, I will focus on a little bit because this has been a huge success of recent times. Now we have 2 options in this space, not yet funded. And the ATAGI recommendations we heard alluded to earlier that don't necessarily line up exactly with the approval, but you can see there's certainly for over 75s it's recommended. COVID, no different vaccines or different vaccine strategies as yet. but we do have more frequent boosters recommended, and I'll touch on that. And then some other vaccines that perhaps aren't as popular to talk about necessarily at the moment. So pneumococcal disease, there's recommendations there. Tetanus and pertussis are an important thing to remember in this population. And of course, shingles, I'll touch on that because that's a big advance in recent times as well. So RSV, we know for people less than 50 who are healthy, and when I plugged healthy less than 50-year-old into Google Images, this is the picture that came up. We know these people get exposed to RSV all the time and typically have mild infection, if anything, usually confined to the upper respiratory tract. And so most people probably, particularly previously, dismiss that as a cold. But we know once you get over 50, and particularly as you increase in age, that the risks go up. So we tend to see more lower tract disease, more significant impacts, hospitalizations, etc. And mortality in some studies has been, approaching 10%. And in really high risk people, so those who've had a transplant, for example, so we've got other immunological issues, the mortality rate's been quoted 70 to 100. So it can be terrible in the vulnerable. But it's not like we just thought to start making RSV vaccines in the last few years. Shortly after it was discovered in the 50s, NIH started making vaccines. But of course, it was probably one of the biggest issues we faced in developing vaccines was it did exactly the opposite of what we wanted. So those who'd received the vaccine got worse disease. And in fact, there were 2 fatalities, and pictured is one of the young children that unfortunately didn't survive an enhanced disease response to that infection. But we learnt a lot from that. And over the journey from then to now, we've been able to successfully crack something that was a big challenge for us. And one of the ways we did that was understanding the F protein. So you'll see the vaccines I'll talk about are focused against this F protein. And one of the big things we had to do is work out what shape we wanted that response to. It changes shape pre to post fusion, get a response against the post fusion form after it binds, doesn't do much. So we had to make those pre-fusion proteins and work out a way to keep them in the right shape and get the type of response that we wanted. And that's what's illustrated here in that timeline. So that brings us to today, where we have 2 options that have done exactly that. So we've got Arexvy, and I don't know how they came up with these names. Maybe some of the representatives can enlighten us later on because they don't really roll off the tongue. Arexvy, RSV, glycoprotein, pre-fusion, combined with the adjuvant, as we've heard, approved a little while ago, actually, overseas. And obviously, we've got some regulatory approvals here not that long ago for 60 years and older. And we've got the other option, Abrysvo. So no adjuvant, RSV A and B, recombinant RSV fusion protein, again, approved a little while ago by the FDA and very recently here in our country as well. Also approved in pregnancy, but I won't be touching on that indication. And just very quickly to flash up some of the evidence, we're fortunate to have quite large clinical trials. And of course, the other thing about this population is it's quite hard to do large clinical trials because of those very comorbidities that I mentioned at the start. You don't want to enrol people that are too unwell in your clinical trial, but you obviously need to have a population that represents those in which you want to use the vaccine. We see the same thing with pregnancy in children and other medical problems, of course. But here we were able to do a large clinical trial which showed a very high level of efficacy. So lower respiratory tract disease, over 80%, severe disease, 94%. So tremendous levels of efficacy. And in terms of the safety, you can look at, if you can see the little bar graph on the bottom right, there was a little bit of a difference, both with some local and systemic reactogenicity, but it was very short-lived. And the other thing we have to remember about the clinical trials is we talk about these solicited adverse events where you ask people every day if they've got these things. If you ask me any day if I'm tired today, I'll say yes. So we have to remember that we're kind of increasing how much of this we capture in the clinical trials. And of course, Abrysvo, very similar in terms of a large clinical trial that demonstrated very high levels of safety and efficacy. You can see their lower respiratory tract illness, so 2 symptoms, 2/3 or 66%, and then more than 3 symptoms, 85%. Slight increase in local reactions in the vaccine compared to placebo. Systemic events were actually similar between the 2 arms. So once again, a very good safety profile. Approved by the TGA at the start of this year, and then relatively recently, the first patient in the country received this vaccine, which was great to see. So that was heavily publicised. Keith Forrest there did the right thing and got that vaccine, but not without its challenges. And there's many more, and we could discuss this at great length. Obviously, I showed the vaccines we use in this population. It's quite a complex landscape with differences between approvals and recommendations and funding. So it's just hard for people to remember what they're due for. And I think a lot of people don't appreciate the significance of some of these infections. RSV, I've had people criticise me in the media saying we made this up. How come we didn't talk about this a couple of years ago? And of course, it's only recently been reportable and we've improved our testing. So we're understanding a lot more, but we need to communicate that risk. We had an excellent question already in the session earlier about Guillain-Barré, and it is a concern and we need to monitor that and let people know. But exactly as you've already heard, there's a whole lot of other things that can contribute to that. And so in terms of comparing the risks and benefits, obviously the benefits outweigh those risks. Timing is a little bit of a difficult one. We see different seasonality. So with our beautiful sunny winters here, our seasonality is a little bit different to what some people in the cooler states might experience. And obviously, potentially the ideal use would be to overlap with the flu vaccine campaign. And we've seen how challenging that's been this year with uptakes below where we want. I mentioned that it's a sort of complex space already, but I think it's also confusing that we've got approvals for 60 and older, but then a recommendation for 75 and older. So again, it means we need to have a little bit of a long conversation about individual risks and benefits. And of course, the funding, not yet funded. And I think most of us would understand there's an inevitable lag between getting something approved and in use before it gets funded. It doesn't mean we don't think it's a good idea, but unfortunately, I think some of the public can perceive that in that way. And we've heard about a lot of this already, but again, I'll just quickly touch on influenza because this has been a big step forward and we had some great data that already showed just how big an improvement that can be in a population that we struggle to get the results that we need. So, of course, we have the two options. So we've got an adjuvanted option for 65s and older, and then we've got a high dose from 60 and older. But again, that doesn't line up with the funding on the NIP being for 65s. And safety, we've seen that is perhaps a slight increase in reactogenicity, but no significant safety concerns that preclude us recommending that. And while obviously our background rates of efficacy vary year to year with flu vaccines anyway, so it's hard to say what the improvement is, studies have suggested a 20 to 25% improvement over the unenhanced or improved vaccines. And just very quickly to go through shingles, again, I think most people in this audience will be very familiar with this. So we know most people have been exposed, but about 1 in 3 will actually develop shingles in their lifetime. So this is a very high burden issue that we face. And in terms of the impact, if we look at pain scores, you can see where that rates. Of course, it's an individual thing. I'm not saying it is more painful than labour pain, of course, but this is a scale that was used and demonstrated that for many people, it's a very severe pain, but it actually has an impact on your quality of life. And just some indicators that were picked out on the right, you can see things like sleep and enjoyment of life were impacted in the majority of people who were surveyed there. And some significant complications can follow. I've got a patient under me in hospital at the moment who's got some very significant neurological complications. He's lost hearing in one side, he can't walk unassisted at the moment. So a very significant burden of disease and can be quite severe. And again, this same concept of immune senescence, our ability to keep this at bay, declining over time so that we get below a theoretical threshold where it becomes an issue and can resurface. And I won't go through this in any detail, just to know, again, there's been a few different studies, different ages, etc. And when we look across the board, even out to 10 years, still very high levels of efficacy, over 80% in those studies. And there were some reactions. Again, we've heard about the potential reactogenicity as a trade-off with adjuvanted vaccines. So if we look at pain, redness and swelling, there were some differences between the two groups, but most of these were on the less severe side and lasted 3 days or less. And if we look at the systemic adverse reactions, a little bit of a similar story. We do see a few more, and these were potentially a little bit greater in the younger in blue, so that's the 50-year-olds versus the 70-year-olds, but the mean duration of these was 2 days or less. So again, what you might really expect from a number of vaccines, to be perfectly honest. And just quickly flashing up some of the guidelines. So recommended for immunocompetent over 50. We know there are people and we've heard about some of the impacts of immune suppression. So younger people can potentially get this as well. But again, a little bit of a difference with funding. That's just a table that shows where that fits in. And just quickly on COVID-19. So again, we know the risk factors for severe disease. Age is a really big one, but so are those comorbidities that accumulate over time. So we don't have an improved or enhanced vaccine for COVID, but what we do have is a different recommendation. And again, I think the complexity of this hasn't necessarily meant that the uptake is anywhere near where it needs to be. So it's very clear from these recommendations, if you're 75 or older, irrespective of any comorbidities, that you're actually recommended to get a booster every 6 months. And then we get these staged recommendations in the younger group, 65 to 74, recommended every 12, can be 6, talk to your healthcare provider. If you're younger, immune compromise becomes a big factor. And I won't go into the kids' recommendations there. So just to summarise, we know the elderly are a particularly challenging group when it comes to all infectious diseases and vaccines. We know the risks of the infections and the consequences are high, outcomes are likely worse. So in many ways, a very high priority group. It's much more challenging to achieve the desired effect for a host of reasons, particularly that immune senescence, and many confounders, including comorbidities and the management of a lot of very significant medical problems, as well as other things like frailty. And we've got some excellent strategies to use to overcome some of these challenges. We've heard a lot about adjuvants already, different dosages, more frequent boosters, and of course, more novel vaccines will come through. Perhaps a patch might provide a solution. There's other technology that's progressing well that might also address some of these challenges. The ones we really want to talk about, though, at the moment, I guess, so that we do get the most bang for our buck, of course, is RSV and particularly with shingles, because we have great options there. Some challenges remain, particularly with RSV, that it's not funded. And so at the moment, there's an expense. But if we look at the burden, I think that's fairly clear. And we've had, obviously, the improvements with influenza that we've seen some great data about just how big that impact is. Maybe the biggest challenge still, though, is uptake. And I think the nursing home story with COVID at the moment tells a story there. We need to do better in that group. And I think we'll see some more improvements come with our advances in technology, like we heard about patches and other technology like self-amplifying mRNA, for example, might be another thing that might prove very useful in this space, but we'll wait and see what comes. Thank you.
Great talk. Thanks, Paul. Questions to Paul? While you're thinking of questions, I'll just check if I'm being told about questions online. Could the other speakers join Paul and we'll have a panel discussion? And thereby we can also go back to that question that we didn't have time for with Michael. But any particular questions to Paul? This says funny question. I'm not laughing. If you have a shingles vaccine at 50 plus years, it's not funded. Is it still beneficial to get this again when funded for it on the NIP when you reach the age of 65? Just thinking of the duration of immunity, is 10 years, is 10 years enough?
Look, I think that remains to be seen. I mean, as with everything with vaccines these days, we can only comment on things that are well supported by data. In terms of redosing, that might be something that's contemplated in the future. I mean, I very quickly flashed up the slide that showed still excellent protection out to 10 years. Beyond that, I guess, remains to be seen. So I guess I can't tell that person to definitely go ahead and do that, but we'll wait and see what the evidence shows.